Assalamu alaikum warahmatullahi wabarakatuh. Welcome to one of our quick sessions in which we summarize together one of the Green Top guidelines. Our guideline today is the most devastating nightmare for most of obstetricians, if not all. We are talking about postpartum hemorrhage. And this guideline is number 52 and coming to you by eMrcog online session. And I don't need to tell you how important is postpartum hemorrhage as a topic in clinical practice or for exams. I'm talking about MRCOG part 1, part 2, part 3 exam in each and every part because it is the third leading cause for maternal deaths in UK. That's why the training for having scenarios or rehearsals, even they are doing rehearsals for how to deal with postpartum hemorrhage. There has to be a multidisciplinary team in each hospital that knows exactly how to deal with postpartum hemorrhage. Every maternity unit should have a multidisciplinary protocol for the management of postpartum hemorrhage too. So you can expect how important it is for us, of course, and for you as an examiner. And for everyone who's watching this video, please pay attention for the points that we are going to highlight. The guideline is very long, it has so much information, and it has a repetitive information that you will find in other guidelines. So I will talk about the point that is not mentioned in other guidelines, like blood transfusion in obstetrics or management of placenta previa or the management of stages of labor, because some points are mentioned there in details, and if we are going to talk about it here, this video will be like 2 hours, and it is a quick session. So let's start. How to minimize the risk of postpartum hemorrhage is a must. How to get familiar with the protocols is very important. The intraoperative management of primary hemorrhage and the secondary hemorrhage management in PREV. First of all, how to minimize your chances for facing postpartum hemorrhage. Detecting and treating the antenatal causes of postpartum hemorrhage will cause you much more pace at the time of delivery. If your patient is suffering from anemia, please deal with it. If your patient has any hematological uh, condition, please deal with it. And here are the 4 T's, the 4 famous T's. Those are the 4 famous causes for a postpartum hemorrhage. The first T is for tone, T for tissue, T for trauma, and T for thrombin. T for tone, we are talking about the uterine tone, of course. Anything that can cause any abnormalities with uterine tone have to be kept in mind. Retained products of conception can cause us postpartum hemorrhage, trauma to any part of the genital tract, abnormality of coagulation, the T for thrombin. It's if whether it is pre-existing or acquired in pregnancy or, God forbid, in DIC, of course. Okay, how to be prepared for a risky patient. What's first to think and to keep in mind that if I have a risky patient, I have to admit this patient to have her delivery in a well occupied hospital, at least hospital with a blood bank. This is number one for me as an obstetrician or a gynecologist or antenatal care doctor. I have to make sure that my patient is going to deliver in the right place. What is the rule management for postpartum hemorrhage? As I said, your hospital have a protocol. You have to be familiar with this protocol. There is a multidisciplinary team for the management of postpartum hemorrhage. You have to know each and every one of those. You have to know when to make calls for your seniors. And of course, if your patient is going to lose or have lost more than a liter and a half, she will be a subject for clinical incident review. So recording is a must. Have to record every and each thing happened this day. Each and everything happened with this woman intraoperatively and postoperatively too. Okay, talking about postpartum hemorrhage, the primary one, we are talking about losing from 500 milliliter or more. And we can categorize them into three categorizations: minor 500 to 1 liter, more than 1 liter is major, and more than 2 liters is severe. How can I categorize my patient into those categories? Should I take the blood loss seen by my eyes, the visual counting? No, visual counting is not recommended. You have to rely on the clinical symptoms and signs for your patient, because previously we used to count towels and soaked swabs, and this is not working anymore. So if the systolic blood pressure is going below 80 and you have worsening tachycardia and tachypnea with altered mental state, that means that your patient is losing blood in excess of 1 liter and a half, and this is huge. We are talking about major to severe blood loss. So clinical signs and symptoms are very important, and keeping the physiology of pregnancy in your mind is a must too. Because of course we all know that our patient is in a hyperdynamic state, and she will have tachypnea and tachycardia anyway. However, just be oriented with those numbers: systolic blood pressure 80 and below, worsening tachypnea and tachycardia. And that's why recording is very important, because your threshold will be put according to the starting point in which your patient was in. My patient went through delivery and her heart rate was 100, and then it becomes 80 in the second stage, it becomes 70 in the third stage. This is worsening of her heartbeats. But if she was like 80 from the start, then I'm okay. She is 80 and remains 80 to the third stage, remains 80 after delivering the baby. So my patient is normal. So clinical signs and symptoms are always dependent on your starting point. As they call it, it's about trending, not about the numbers. Okay, what to do to minimize the blood loss at the delivery itself? Should we use a uterine massage to prevent the happening of postpartum hemorrhage? No, it is of no benefit. And please take care here that it should not be confused with uterine massage as a prophylaxis and as a treatment for postpartum hemorrhage. Here we are talking as a prophylaxis. As a prophylaxis, it has no use. Oxytocin, of course, can be used vaginally in a vaginal delivery or CS delivery. Vaginally, we will use it IM, 10 units, 10 international units IM if it's vaginal delivery, 5 units slow IV if you are having a CS delivery. Can we consider tranexamic acid? Yes, we can consider it in high risky patients, especially if we are having a CS delivery. Okay, what are the protocols that I have to be familiar with dealing with postpartum hemorrhage? If we are talking about hemorrhage, then we have to know what are my steps for resuscitation. And I think it is the time to ask you a very important question and need you to be focused. Let's suppose I have a vaginal delivery now and my patient was okay up to a point that she become unresponsive to me. I'm calling her and she's not answering. What is my first step to do? And I need you to answer this in the comments. And for people who are with me now, if you can answer me quickly, what is the first step I should do for my patient who is responsiveness to me now? She become unresponsiveness, or you can say coma. I wouldn't say coma. Just unresponsive. Yeah, looking for a source of bleeding. Okay, pressure. Checking blood pressure. Okay, no, none of those. The first thing you have to do to resuscitate your patient, if she's coming unresponsive to you, is ABC: airway, breathing, circulation. Do not overlook airway and breathing, please. Please, airway and breathing are life saving, but pressuring on the wound or detecting the source of bleeding is not life saving if you have a catastrophe in airway or breathing. So, first thing to do is airway, breathing, then circulation. And the tools of resuscitation, with or without clinical shock, of course, is intravenous access. If I have uh, intravenous access, I will be able to handle my patient in terms of fluids or blood transfusion or whatever. Because if I don't have accessible intravenous lines and my patient have went into a shock, I will not able to find any vein to access into. So intravenous access is a must. Very rapid and huge venous sample, about 20 milliliter, has to be taken out for group screening, full blood picture, coagulation screen, especially fibrinogen, because as we said before in the blood transfusion guideline, fibrinogen is my tool to decide if my patient is going to need cryoprecipitate or not. So I have to keep eyes on fibrinogen, and fibrinogen is not a routine test, so you have to write it down. You have to write coagulation screen plus fibrinogen. Of course, monitoring of pulse rate and blood pressure, and the comments of warmed crystalloid infusion. Why warmed crystalloid infusion? And why we are emphasizing on this point here? Because if you don't keep this point in your mind, it will take you a huge time to warm your infusions before installment, and this will take time, and you have to make use of every second, not every minute. So if your patient is losing blood from 500 to a liter, you have to make IV access, get the blood tests, get your sample, the huge sample, 20 milliliter, and commence the warm crystalloid infusions. So be prepared and warm your infusions ahead. For major postpartum hemorrhage, of course, AB, airway, breathing, and then circulation. Position your patient flat. Keep your woman warm with every tool possible around you. Transfuse blood as soon as possible, and please don't wait for cross matching. You can use O negative blood until the appropriate cross-matched blood come. Do not wait for cross-matching because you are in need for very rapid transfusion now. And this is discussed in details in the video of blood transfusion in obstetrics. Until blood is available, I don't have blood yet. What should I do? I can give her up to 3.5 liters of warmed clear fluids, initially 2 liters of crystalloids, of course, and then 1.5 liters of crystalloids. Starch is not recommended at all. Do not use any fluid expanders. Uh, I think those points are discussed in details. You will find it in ATLS books, Advanced Trauma Life Support. Why to use this solution, why not to use this solution. But as for you as a obstetrician, you have to know that crystalloids are the best for your patient. You will give it warmly. You will give it in a manner of 2 liters first, then 1 liter later until blood comes. You have to keep in your mind that when you use this amount of intravenous fluids, you will be in need for platelets. So monitoring and CBC is crucial, guys. You have to draw your blood and keep recording your patient's CBC's parameters. The best equipment available should be used to achieve rapid warmed infusion of fluids, as I said, and do not use special blood filters because they will slow the infusions. Okay. For major postpartum hemorrhage, we have to withdraw, of course, the venous sample and order 4 units minimally. We will order cross-matched unit, of course. What if cross-matched unit is unavailable? I can use O negative immediately without any thinking. Renal and liver functions, those was not ordered before in minimal blood loss. And we will monitor temperature every 15 minutes. We will have 2 peripheral cannulae, large ones. And we will do what is called by modified early obstetric warning score. What is this score? We will see, but first, always consider that your patient can be transferred to intensive therapy unit, and always consider that you will need artery line monitoring. So let's see the chart. The chart will make us remind. This is the chart, early warning chart. I cannot maximize it more than this, but you can find it in Appendix 4 in the guideline. It has monitoring for everything: temperature, heart rate, systolic blood pressure, diastolic blood pressure, kind of fluids, if there is nausea, pain, neuro response, proteinuria, everything. And accordingly, if your score is declining, that means that your patient is in hazard, and that means that you have to call for help. Okay, what type of solutions we can use? Crystalloids, as I said, colloids up to 1.5 only. Blood, as I said, if immediate transfusion is indicated, go for O negative groups. Fresh frozen plasma when to use it, and blood and cryoprecipitate is discussed in details in the video of blood transfusion in obstetrics. I just want to remind you that do not wait for platelets to come by 5. I want you to take an action, whether your platelets came 7.5 or less. Do not wait for your platelets to come out to be 5. And the cryoprecipitate, if the fibrinogen is less than 2, please get 2 poles of cryoprecipitates immediately. The fresh frozen plasma is monitored by PT and PPTT, and both have to be 1.5 times the normal. You can give it in a dose of 12 to 15 milliliter per kg, and you have to give it after giving her 4 units of blood. So for every 4 units of blood, you will give fresh frozen plasma. If you don't have hemostatic tests available, you will give 4 units of fresh frozen plasma whatsoever. Okay, our aim is to keep the hemoglobin above 80 gram per liter, the platelet count greater than 5, and do not wait until it becomes 5. The prothrombin time less than 1.5 times normal, and the APTT less than 1.5 times normal, and the fibrinogen greater than 2 gram per liter. Okay, our chart here is giving us a hint about what to do. First thing of all, call for help. Alert the hematologist, alert the blood transfusion laboratory, alert the consultant obstetrician on call, and the resuscitation is ABC, oxygen mask for any patient, even if her saturation is above 90% or 98%, even above or normal. If she has the optimum oxygen saturation, give her oxygen mask. This is a must, 15 liters per minute. Fluid balance, as we said, blood transfusion, blood products, keep the patient warm, do your monitoring and investigations, medical treatment we will talk about. And okay, have a look on this before we go further. We will call for help, we will resusc, we will do our monitoring and investigations, and we will commence our medical treatment before going to any further surgical management. The intraoperative management will be medical and surgical, of course. If my pharmacological measures fail, then I have to do my surgical intervention. And what is my first line for surgical intervention? It will be intrauterine balloon tamponade, not anything else, because it is considered the most effective according to research results, of course. Secondly, the conservative surgical interventions, and here we are talking about the cascade for hemostat, ligations, blood vessels ligation. And our last resort is hysterectomy. So first is intrauterine balloon tamponade, yes. Second is conservative surgical intervention, like the stepwise uterine devascularization and internal iliac artery ligation. Yes, it is in order. First thing, one uterine artery, both uterine arteries, low uterine arteries, one ovarian artery, both ovarian arteries. Yes, and finally internal iliac artery ligation. Embolization is still in research. Yes, it is very effective for control of hemorrhage. However, it's kind of a delayed intervention. You can use selective arterial occlusion or embolization. but it is not considered as a first line of treatment. Ballooning is considered the first line of management. Okay, it is recommended that a laminated diagram of brace suture technique is to be kept in theater so everyone can use in need. And ideally, when feasible, a second experienced clinician should be involved in the decision for hysterectomy, of course. Okay, here comes our medical treatment that is discussed in details in labor management. Uh, First of all, wrap up the uterine fundus. We have said that massage has no use in prophylaxis, but it is very efficient in controlling the ongoing bleeding because it enhances the uterine contractility. Empty the bladder, of course, so Foley catheter is a very important step in our resuscitation and preparation for our patient. Oxytocin, starting with 5 international units, low IV, and repeat if necessary. And the doses of oxytocin is recorded in our chart. Ergometrine also, if used, will be recorded in our hemorrhage chart. Oxytocin infusion if we are going to use a huge amount. Carboprost, of course, it can be used intramuscular every 15 minutes. Misoprostol sublingually, 800 micrograms, yes. Consider tranexamic acid, as we said before. We can have it with oxytocin simultaneously. And if we going to discuss this, it will take huge time. So please try to revise management stages of labor. And inshallah, I will try to make a video that talks about the 3 guidelines together to emphasize on the very important points in each of them that come in common in the 3 guidelines: the postpartum hemorrhage, placenta previa management, blood transfusion, and if possible, labor management too. Now, finally, how to deal with secondary hemorrhage. We mean by secondary hemorrhage is excessive bleeding between 24 hours up to 12 weeks postnatally. Most important cause of secondary hemorrhage is infection, endometritis. Yes. So what you have to do, we have to assess vaginal microbiology by high vaginal and endocervical swabs and give the appropriate antibiotic accordingly. Pelvic ultrasound, of course, is a very good helper for us to exclude the presence of retained products of conception. Um, Surgical evacuation can be done, of course, but please make sure that surgical evacuation of retained placental tissue should be undertaken or supervised by an experienced clinician because the friability is very high in those patients and uterine perforation can be very easily commenced. So just take care of this point, and I think we have reached the end of our video. Thank you so much for watching, and don't forget to revise the other guidelines. If you have any question, you can write it in the comments. If you have any comment on the video, you can also write. Please don't forget to see the video talking about blood transfusion in obstetrics because it's very important. See you next time, and wish you all good luck in the exams. Thank you.